Welcome back to our session on New Hampshire Rapid Response Access Point, Hope for Those in Crisis. We are really thankful for a sponsorship from WellSense for sponsoring this workshop. Please allow me to introduce you to our speakers, Eric Eason, Jeffrey Hilt, Dennis Walker, and Josh F. And in January 2022, New Hampshire launched its Rapid Response Access Point, providing granted staters in a mental health or substance use crisis 24/7 phone, text, or chat access to mental health professionals. In this session, you'll hear from Eric Jeffrey from Beacon Health Options and Dennis Walker from the Seacoast Mental Health Mobile Crisis Response Team. We will also have Josh, who will share his personal perspective. Okay, Kimberly, would you stop sharing? And I will have Eric pull up his slides first, and I'll hand it over to you, Eric.
Thanks, Liz. I'm actually going to let Jeff introduce himself first, and then I'll take over from Jeff. Jeff?
Good morning. It's great to see everybody. Happy to be here. Thanks for that introduction, Liz. My name is Jeff Height. I am a clinical programs director with Beacon Health Options, and I've been working closely in New Hampshire over the last 8 months or so, and also in support of the New Hampshire Rapid Response Access Point. So very excited to be here this morning and talk about our launch and how things have gone and the status of this new program as of here we are in April.
Thanks, Jeff. And I'm Eric Eason, also with Beacon Health Options. I'm a licensed counselor. My licensure actually is in Georgia. I just relocated to New Hampshire in January to help Beacon manage this account here in New Hampshire. I'm very pleased to be working with DHHS and also as an extension of Beacon to help make this contract serve and do what we want it to do for the people of New Hampshire. Met a lot of great people here. There's just a lot of really good work going on. So we're going to talk today about the New Hampshire Rapid Response Access Point. As Liz mentioned earlier, this service did go live January 1st of this year. And there are a few primary purposes that the access point has. First of all, we serve as a 24/7 crisis line, and we serve phone calls, texts, and chats from those who are seeking help for themselves or for a friend, family member, or loved one, or even someone they may be working with professionally who's in crisis and needs some sort of support. We're able to provide linkage to local community-based resources, including primarily to services that are provided by our local community mental health centers, or CMHCs. These are the same agencies that have been serving the public here in New Hampshire for many years. So we are a new addition to this service, but they are well-established quality providers of care that continue to do that work. Another part of the service that we are offering is the dispatch of live mobile rapid response teams for those who might need more direct and urgent intervention than we can provide via phone, text, or chat. These teams do go out, and Dennis will be talking much more in detail about this, but these teams do go out primarily into the public to have live encounters. There are some situations where they might be offering services remotely or virtually. And again, Dennis can talk a little bit more about that in his part of the presentation today. We also have developed a closed loop referral system for crisis appointments. What that means by closed loop, it just means we have an electronic way of making the referral to the mental health center and then confirming that the mental health center was able to receive that. So we're closing that loop on the communication to make certain that we didn't drop a ball there. So those are the services that Beacon is supporting here in New Hampshire through the access point. I want to talk a little bit about what the caller or texter or chatter, we'll say, might expect when they reach out to our call center. So I know that this slide is pretty busy. It's actually less busy than one I've used previously, so it's a bit of an improvement, but I will go through a bit with you today and help you understand kind of what we're going to be doing for you. So left to right, you'll see the progression through a series of steps. Across the top, you'll notice the headings of kind of what's going on at any particular time. And down at the bottom is some more information around kind of the back door or back room, we'll say, processes that we use to support these particular processes. So you'll notice, of course, on the left-hand side, we start out by a person reaching out via call, text, or chat. Once they reach one of our call takers, we're going to do a clinical triage that does involve a safety assessment. That is us trying to determine what the immediate need is. If there is some sort of immediate urgent level of care, if this is something that can be managed safely by phone, or if we need to escalate this for other types of intervention. We do a basic clinical assessment to determine kind of what the risk level is at that moment. We work with the caller to try and offer means of de-escalating that crisis. So we offer support, we help the callers identify their existing resources. We seek to understand kind of what the concerns are that are going on with the person. And we try to help that person develop an appropriate plan for how to deal with that crisis in the moment. We're then able to either help that person use their existing resources and coping skills to de-escalate independently, or we can link them with appropriate resources if need be. If we do make the decision to go on and make some sort of referral, you'll notice in the next section that we're able to do that primarily electronically. So if there is a really acute need and we need to engage 911, that happens very much like you might expect it does. We pick up the phone, we call 911, we engage with them, and they dispatch. That happens in a very, very small number of encounters that we manage at the access point. Those would be cases where someone may have already done something to harm themselves, or might be in some sort of immediate danger that really is just too unsafe to allow to have them wait in the community for care to arrive. However, the majority of our calls are actually de-escalated with nothing more than that initial contact with us through phone call or text or chat. We're de-escalating somewhere in the neighborhood of about 75% of callers just with our interactions alone, and then perhaps linking them on to additional resources in the community. There is about a 25%, about 25% of the people that reach out to us do receive a mobile crisis dispatch. So that is another type of service we're able to link to. We use our software that we have developed in conjunction with Bamboo Health or Open Beds to create a kind of electronic referral for mobile crisis. And again, these are teams of people that are able to come out into the community to help folks in crisis, to assess their needs, to link them to resources, and to help them manage that crisis themselves. We also are finding with these mobile teams that they're doing a really terrific job. So in addition to the 75+% de-escalation that the access point is seeing, the mobile teams are also seeing very high de-escalation rates as well. So even if we are unable to escalate via phone and we have to send a mobile team out, we're finding that largely the mobile teams are also able to de-escalate the majority of folks that they're engaged with. And that prevents folks from having to do things like go to an ER or call 911 for help, right? So that is one of the large goals of this program, is to reduce the need for people to reach out through these other channels to get mental health support. For instance, I know that in New Hampshire, there's kind of a problem with boarding right now, people waiting in the ERs on hospital beds. And what we're trying to do here is to reduce the number of folks who were having to go to the ER in the first place, thereby overall reducing that boarding problem. That's kind of a long-term major goal of this program. We do have the ability to do some follow-up care as well. You'll notice in the far right box that we have peer support specialists who are able to reach out and engage with folks. And these are peer support specialists who are employed by the access point. There are peer support specialists with the mobile teams as well, but this slide specifically speaks to what we're doing with the access point. So that follow-up does consist of some follow-up calls to ask how the person is doing, to make sure that they got the kind of help that they need, that they're still okay, and see if they need any additional resources. We do follow up for anyone who is not linked to a mobile crisis dispatch or other type of higher level resource. So these would be the folks that we have de-escalated purely by phone text, or chat. Those are the folks that we're doing follow-up. Along the bottom, just a few, again, these are kind of backroom things that we're using, but we do a lot of work around using our technology to monitor our performance. How well are we answering the phone? Of course, we're keeping careful records so that if someone calls in crisis, we're able to kind of reference what may have worked with that person in the past. And then we're also able to use that electronic software to more effectively dispatch teams. The software actually allows us to look in a map, see the caller's location, and see the mobile resource location to determine which team might be available to respond closest. We're primarily dispatching teams that serve a particular region, but sometimes we might even pull a team from a different location in the state if they happen to be the closest team available. The goal is to get someone seen by mobile crisis within about an hour, if that is considered an appropriate linkage. If we're not able to find a team available within an hour, then we'll talk through some alternative options with that person and try to figure out the best way forward at that point. So we've had a busy couple of months. I'm going to let Jeff dive in a little bit and go through some data. So Jeff, I'll advance these one at a time if you want to talk through them.
Thank you, Eric. Absolutely. Like Eric mentioned, we went live January 1, and it has been quite busy from the start. So we've got a couple of data elements that we want to share today. Please keep in mind that we are still working to refine all of our data reporting. It's going to take us a period of time to make sure we understand the nature of the work that we're doing, all of the incoming calls, how we're transitioning to the rapid response teams, and then the outcome of those interventions. So our data will be improving in the months to come. But so far, a couple of items that we want to share. In the month of January, we registered 1,565 unique contacts, or had contact from 1,565 unique individuals via the access point. And that would include phone calls, texts, and chats. Of those 1,565 contacts, the next data element that I want to share is our inbound phone line data. In January, you can see the data there on the left. In January, we had approximately 4,000 inbound calls coming into the access point. That dipped just slightly in February. We had just something like 3,800. And then between the 2 months, between January and February, we approached nearly 8,000 calls, texts, and chats. And as Eric had mentioned, I think in passing, we're able to resolve approximately 75% of those at the point of contact with the access point. And then another 25% often result in the rapid response dispatch or rapid response deployment. So the graph on the lower right-hand side is a summary of the mobile dispatches or the rapid response deployments that Dennis will be highlighting in a few minutes. Just to get into that data a little bit more, in January, we identified dispatching teams 727 times. That dipped a little bit in February to 549. And through the months of January and February, we have approximately 1,276 mobile deployment or rapid response dispatches. So that's the high level data. Of course, like I mentioned, we will be drilling down and offering a higher level of data analysis in the months to come.
Thanks, Jeff. And then I just want to I realized that in some of my recent presentations that I have actually failed to advertise the way to reach out. And so I wanted to amend that by adding this slide to the presentation today. This information is actually available on our website. You'll notice the website is listed there, but I do want to just put in a plug for anyone who needs this number for themselves, or if they need it for a friend, a family member, a loved one, want to share this, want to get it and share it with your clientele if you are in some sort of business that might serve the public in some way. So there are two ways to reach out. You can call or text by using that phone number, or you can chat with us at the website that you see there. At that website, there also are some videos that explain a little bit more about the service, and we have some downloadable resources such as flyers and business cards that can be used for helping to get the word out. So that's all for the call center portion of this presentation. I'm going to turn it back over for us to move on to the next section.
There we go. I thought I was going to be reading some little print, so I was a little nervous because I'm need glasses actually. So thank you. First of all, thank you to NAMI and thank you to Liz especially for organizing all of this. The amazing advocacy of NAMI in New Hampshire, it's just been so impressive. So really, really grateful for the invite and to be able to come and talk about mobile crisis. So my name is Dennis Walker, and my job at Seacoast Mental Health is to oversee the operations of mobile crisis. I oversee some other programs too. But I'm also a licensed clinical social worker, and I've been out on a number of mobile interactions, and super excited to kind of share what that's like from our perspective, and talk just a little bit about from start to finish, kind of the dynamics of a clinician as they're kind of heading towards you on the mobile front. So if we could get the next slide up. Thank you. So Jeff and Eric really did a nice job kind of articulating everything that happens when you call into the access point. And Eric kind of outlined that through one of their applications called OpenBeds, they communicate everything that they initially received from those calls to the mobile clinicians. And the mobile clinicians get this really nice array of information on the call, gives us all the demographics, your location, what the problem was, and it's a fantastic start for us. Because once we receive that information, we can check our own electronic health records to see if you're an active client with us, and we can learn even more than what was initially indicated to Beacon. So, so what happens when we receive that information is we'll definitely check our own data banks, if you will, try to figure out if we already know you. We might do a little bit of reading. This is happening very quickly. And then we're going to give you a call. The number that you have given the access point folks will come through to us, and we're going to give you a call, and we're going to introduce ourselves. We're going to tell you kind of what our names are, what kind of car we're driving, and when we're going to arrive. Now, one of the unique features of this is when mobile crisis is deploying to your home, we're going to come in a two-person team. So the team members will be a master's clinician and a peer support person. So the master's clinician will be somebody who's very, very good at managing a crisis. And the peer support person will be somebody with shared experience. And what we're finding is that this is a great combination of teamwork to kind of come in and help you resolve the crisis. And it's the same model that many folks have incorporated around the country, many states. And many of you might know that there's some differences, right? Master's level clinician is somebody who has gone to graduate school and they've trained specifically on how to help people in a crisis. And the peer support folks have that shared experience. They may have had similar issues that they've overcome. And so you're really able to get some clinical expertise from the master's clinician and some shared experience from the peer support folks. And so far, people are saying that they really love that combination of support coming in. So one of the things that we're able to do in these two-person deployments is as we're driving over, we'll call you. We'll not only tell you who we are, what our names are, what our car looks like, but we're going to start asking some questions about the crisis itself. We might even ask you some of the same questions that the Beacon folks have already asked you, what we're trying to do is make sure that all the data that we have so far is accurate. And we're really trying to speed up the process. So you might ask, well, why is speed so important? Well, we know that this is a behavioral health crisis, and we know, working with people over the years, is that you have to get to the person quickly, and you have to figure out exactly what somebody needs as quickly as possible. The longer that somebody has to wait, the longer we fear that people won't get the help that they need. So it's super important that we start the process as soon as possible. So as we're driving over in a two-person team, the person not driving, of course, will call you and start talking to you. And we might ask some similar questions again that the Beacon folks have asked, like, okay, is there anybody else in the home or in the apartment that we need to know about? Are there any pets or any dogs? And so, but the process is starting right when we get in the car. We've already done some prep by reading the deployment stuff that Beacon have sent us. We'll check our electronic health record, and we'll call you and we'll get on the way. Speed is so important to us that we've already prepped a lot of things that we want to take along with us. We'll have all of our scales and our information all ready to go. So we're just jumping in our car and we're heading over to get to you. All right, next slide. All right, so when we arrive on scene, and you can advance to the next slide, please. So we're going to arrive on scene, and the whole reason for being there, as everybody knows, is we're trying to figure out the crisis. We're trying to figure out all sorts of things, like how long it's been happening. What have you tried to fix the problem in the past? What are the current safety needs? We're trying to figure out a whole host of things. We're trying to figure out, too, something called level of care. And what level of care just simply means is, what are your options given the situation? What are all the options that you can look at? Now, sometimes a crisis has moved along so profoundly and is so extreme that our level of care has to rise up, or the level of care that we'll recommend has to rise up to that severity. But infrequently, and I think Eric actually talked about this, and Jeff as well, the highest percentage of times when we're coming into somebody's home, they are staying there, and we're able to kind of create a safety plan or provide care. I'll talk a little bit about that, so that folks can stay in their home. We have heard so many stories over the years of folks not knowing what to do. They end up going to the emergency department. The emergency departments at local hospitals are very busy places. Very noisy. You have to tell your story 3 or 4 times. You might have to wait to get medically cleared. And folks have told us time and time again, we wish there were an alternative. And that's why I'm just so excited. Now that mobile crisis is here in New Hampshire fully, in a fully integrated system, I'm so excited for people, because you're going to have a lot of different options. And certainly that option is always there for you to go to the emergency department. But when you can get the care that you need and some of the same analysis that you'd get at a hospital in the comfort of your own home, many folks kind of will take that. So we're collecting information, and we're really trying to customize a plan, especially for you, based on the severity of the problem. Now, if folks are available inside the home, say if you might live with a significant other, or you might live with family, we definitely want to hear from them as well. Unless you make a special request that you don't want that to happen. A lot of good things can come from us being able to talk to your loved ones or significant other. And oftentimes what we've found is if we're able to get additional information, we can create even a better plan. So we really like to do that when possible. Not everybody has folks living with them, but whenever possible, we'd like to hear from those folks. And it really, again, provides us with a real 360 view of what's going on and how long the problem's been going on. And we're able just to offer more options if we can hear from the folks who really care about you. All right, next slide. So what to expect after we collect all the information? We really want to customize the plan for you. So part of what happens, and I will say too that there are 10 different mobile teams, and there'll be some variations throughout the state. We will basically all be collecting the same information, but there's some variations in process. I can tell you what happens on the Seacoast, and when you're working with the Seacoast mental health clinician. We're going to collect the information that we need, and then we're going to excuse ourselves. We're going to walk outside the apartment or the home, get back into our car, and call either a clinical manager or a psychiatrist, or maybe even both. And why do we do that? Well, it's part of our process. We like to have as many folks involved in the decision as possible. And sometimes these situations are so complex, you need different types of professionals. So at Seacoast, we're able to call our psychiatrists, and they're able to offer a psychiatric point of view and a medical point of view to things. And it can really help us dig in a depth way to understanding the situation even more. So we're going to excuse ourselves. We're going to walk out. We're going to talk to our managers and our psychiatrists. And we're going to come to, we're going to have a menu of options for you. We might have a primary plan in mind. And we'll go back in and we'll discuss all the options that are available to you. When appropriate, we're going to talk to your family and your loved ones, and we'll all kind of talk together in terms of the best way to move forward. So it's a real group process where we're all kind of sharing ideas and sharing insights and looking at the full menu of options. All right, and the next slide. So we're going to make those decisions, and then we're going to share those with you. And before I just talk about this slide, once we present the plan for you, it can look like a lot of different things. We oftentimes will provide an outpatient plan for you where you get to stay in your home or apartment. Basically, just what that means is you don't require any kind of higher level of care, like going to an emergency department or psychiatric hospitalization. And we feel like we can work with you. So what would that look like? Well, you might already have providers. We might connect with them and see if we can get you a sooner appointment with them. We might call you, if you don't have those providers, we might take you on a temporary basis, so we might do some crisis stabilization. We might have our peer support folks call you the following day. Might do some, we have Zoom capabilities, so we can hold on to you and care for you until you're able to either see your established providers, or maybe if you don't have providers, we'll get you an appointment inside the community mental health centers. If you don't want that, we might be able to help you find some folks in the community. So there's a whole host of options from outpatient to inpatient and in between. There's partial hospitalizations and intensive outpatient programs. So we're really going to try to tailor those programs. But I think what I want people to know is it's not just we come in on that first night or evening and you don't hear from us again. We're going to call you the following day. We're going to check in. We're going to make sure that the plan that we created is something that still works for you the following day. I often say to people, we're all going to agree upon this plan, this particular plan, but that might change in the next hour, the next day, the next week. And you can always call back and speak to the Access Point folks who can deploy the Community Mental Health Center mobile teams. So just because we start down one path, it doesn't mean that couldn't change the next day or the next week. And I want everybody to understand that these crisis situations are often fluid. Often we feel like in the moment, like, all right, this is going to be the plan that's going to work for me. But if it changes, it changes, and we simply kind of adapt and change the plan. So things can change, and they often do. So okay, so this slide, which is my last slide, is just talking about going to schools and going to primary care. We can really go anywhere, which I think is really kind of neat. But we can not only go to schools, but we can go to primary care. We can meet you at a coffee shop, bookstore. We could do a bunch of different things like that. So it doesn't just have to be in your home, and it doesn't necessarily have to be in person either. We've had a lot of situations, excuse me, where folks will call the Access Point. Excuse me. They'll call the Access Point and they'll say, okay, yep, that'd be great if Mobile Crisis can come to my home. Mobile Crisis will call, and then we'll start having a conversation, and then folks change their mind, like, oh, gee, is there any way we could do this through Zoom, for example? Absolutely. Some folks don't want to meet us, don't want us to come into their home, or we had one family who had some big dogs, and the dogs don't like strangers coming into their house, and they changed their mind at the last minute, and we were like, no problem. We turned our car around, got back to our office, turned on our computers, we were able to kind of see you through Zoom. So there's so many different options and so many ways for us to adapt, depending on if you don't want an in-person kind of a situation. So the schools, we go to schools, and we've noticed what tends to happen at the schools is we'll get a call from a guidance counselor or a school counselor. Well, they'll call the Access Point first. The Access Point will call us. While we're on our way, we'll call the person of record, which is usually the guidance counselor. We'll start talking about the case. The way this has generally worked in these situations is that the guidance folks will either call the parents first and tell them they're going to call Mobile Crisis, or in the name of time and getting somebody out there quickly, they'll call the Access Point first, and then they'll call the parents. And you certainly need the permission for the parents to do all this. And so these things happen in a fluid way. Generally, we're arriving, the parents are agreeing, and we're arriving on scene. Sometimes we arrive and everybody's there together. Sometimes, given the situation, if the parents have said, given a verbal yes over the phone, we'll get there and we'll start kind of talking to the counselor, or maybe talking to the child, and getting a good feel for it. Of course, we need to speak to the parents to get a full, picture of the crisis. So all these things kind of happen. They're fluid, but we're really trying to. Same with the primary care folks. We're really trying to get all the information we can in the beginning, and the more information we're armed with, as far as you might be somebody that we already know through our agency, but we're trying to gather that information so that when we come on scene, we already know a lot, and now we can really start hearing about the current crisis, start hearing about what you've tried to do to fix it, what your family has tried to do to help you, and then developing that really tailored, comprehensive plan that meets your needs at the time. So super, super excited that we have Mobile Crisis now as an option in the state, and very much we'll look forward to hearing some of the questions that come in today. So thank you.
Thank you, Dennis. So before we get to the Q&A, and there are some questions in the Q&A, we'll answer them towards the end of the presentation, but we're going to invite Josh, who will share his perspective as someone who has used Rapid Response Access Point. So welcome, Josh, and thank you for being here today to share your perspective.
Thank you for having me.
So the first question I would like to ask is, what was the date that you contacted Rapid Response Access Point?
It was February 18th of 2022.
Okay. And can you tell us the reason that you decided to contact them?
My depression had been getting a lot worse, and I was feeling really suicidal. My friend had to convince me that I was sick enough to get help because I was worried that other people needed help more than me. So when she convinced me that it was okay, I decided to contact them.
Okay. And what was the way that you outreach to them? How did you contact them?
I went to the New Hampshire 988 website and chatted through there.
Okay. So can you tell us a little bit about your experience and the person that you chatted with?
When I got on the chat, they asked me some basic questions like, they wanted to know if I was suicidal, what my problem was, like what I was having a problem with, or they wanted to know if there was any guns in the house for safety issues and everything like that. When they realized I was suicidal, they wanted to know, like if I had a plan. And when I told them that I wanted to take pills, they asked about giving them to my mom, because I told them my mom lives with me and I didn't want to give them to my mom. So they suggested having the mobile crisis team come out to my house. And they asked for my consent for that, which I was very grateful for. And I said that that was okay. And so they stayed on the chat with me until the mobile crisis team got to my house.
So can you give an estimate of how long you think it was before before mobile crisis response team came to your home?
I think it was about 10 to 15 minutes. It wasn't very long at all.
Okay. And who did you communicate with?
On the phone before they came in my house, well, I think it was the evaluator, called my phone and just made sure that they were at the right house.
Okay.
And I told them that my mom was downstairs waiting for them. And they came up to my room and they talked to me.
So you talked with the person from Mobile Crisis Response Team, and I'm sorry, I think I messed up on my questions here a little bit. The people who were with Mobile Crisis Response Team, who arrived and who are the people? It was more than one person, correct?
Yeah, I think it was an evaluator and who I think was a peer worker, but I can't remember exactly.
Okay. And so what was the outcome of speaking with the people from Mobile Crisis Response Team?
So after I had told them what I was dealing with, they decided that I should go to the emergency room for the night. I had a couple of choices with that. It was either go to the local hospital or go to one a little bit farther away and get evaluated all over again.
Mhm.
At that point, I chose to bring my mom in to make that decision, but I was given a decision first, which I really appreciated. And my mom decided to bring me to the emergency room closest to where I live.
Okay. So upon arrival at the hospital, how long did you have to wait?
That was also only about 10 minutes. They had already been aware that I was on my way. The mobile crisis team had called them.
Okay, and how did things go at the hospital?
When I got called back, my mom left and they brought me back and I didn't have to do any of the stuff I normally do, like get blood work or anything. And I didn't have to explain my story over and over again like I normally do. They had already been told my story, which I was very grateful for that. I was also very grateful that no cops had to show up or anything like that.
So what decision was made about your crisis needs?
So I stayed in the ER overnight, and then the next day, two people from the local mental health center showed up. One was a crisis evaluator and one was a peer worker. And we decided that I could set up a safety plan and my mom would lock up my meds and I would have appointments with my peer worker once a week and I would see my psychiatrist on Monday.
Okay. So upon leaving, well, I think you answered that one. That was your plan upon leaving the hospital. So, so for you, Josh, so you at that point you left the hospital and returned home. Is that
Yes.
correct? Yes. Okay, with that plan in place. So what was the value of rapid response access point for you, Josh?
I really liked that there were 3 options for how I could communicate with them because
Mhm.
I'm really not a phone person. I also liked that they have the option for coming out to your house
Mhm.
instead of just automatically having to go to the ER. It felt um it felt safer, I think, for me to have people come to me and have that face-to-face communication with people who I felt actually cared and understood and were there to help me. And I knew they were doing things for me to get better, not to me.
Absolutely. So if you could make a recommendation to people about rapid response access point, what would it be?
I would say if you're even questioning if you need to contact them, go ahead and contact them. And you don't have to go through this alone and just take care of yourself.
That's a great message, Josh. Thank you so much for sharing your story with us today. And so at this point, we will go ahead and we will take some questions. So if folks want to go ahead and ask any questions that they have in the Q&A, they will be available for all panelists. Josh, Jeffrey, Eric, and Dennis. So if you want your question to be specific to a panel member, please note that, but otherwise we will start to ask some questions. And there are a few that we have answered in the chat, but I just think that some of those are going to be valuable for lots of people. So I'll go ahead and read them aloud. And Josh, you're getting lots of thanks for sharing your story. We really appreciate that. So the first question, is there a minimum age for a person to chat, text, or call, or is there a protocol if the person is a minor?
I can start with that, and Jeff, you can add anything. There is no limit on age. We will engage with any person who reaches out to us, regardless of age. There would be some questions, of course, of consent if we started talking about trying to link to services. Certainly, if we were going to engage with mobile crisis, we would try to get the consent of a guardian or parent to be involved. But we kind of handle those case by case. Certainly, we don't want to engage treatment for anyone without consent. But in the realm of crisis, there is kind of an urgency to get people help. And we would not want the inability to seek consent to be a barrier to perhaps saving someone's life. So it is very case by case.
Yeah, I think Eric said it well. I think he covered most everything. I think we certainly, from a clinical perspective, want to first get the information and then involve family when appropriate and as quickly as possible to make sure that we're getting support to the crisis.
Okay. What is the average wait time for response for phone or text, or is it answered immediately?
So I got a little overzealous and started answering questions, but I'll reiterate my
I
answer.
know, I do think that they're valuable to everyone, so
No, I
that's why
agree.
we're.
I agree. I'm happy to do it again. So I do want to let people know that occasionally, there might be heavy volume and there may be the wait time might be somewhat longer than this. However, the vast majority of the time, we're answering all outreaches in a matter of seconds, like 10 seconds or less, for the vast majority of contacts to our contact center. So unless it happens to be a moment when we're just very saturated with volume, you should expect to hear back within just a few seconds.
So are you the local respondents for the National Suicide Prevention Line and in the near future 988 in New Hampshire? And are there other call centers in New Hampshire?
Another one I had already answered, so I'll reiterate, and then Jeff, I'm going to let you jump in. Headrest has been and continues to be an answer point for the National Suicide Prevention Lifeline in New Hampshire. So we are not replacing Headrest in any way. We are just an added service here in New Hampshire. Beacon is in the process of being certified as an answer point for the National Suicide Prevention Lifeline. We anticipate that certification this month, actually. And as soon as we've got that certification and can work out there are some technical logistical details you have to go through to get connected to the network. Once we've done that, by the time that we go live in July with 988, the intention is for both Headrest and Beacon to serve as answer points for the National Suicide Prevention Lifeline. And that will be for calls, texts, and chats. Both agencies would be able to do both for the NSPL network.
Yeah, again, such a complete answer. I'm not sure. I'm not sure there's a lot more to offer. I would say yes. Eric nailed it. Boom, right there. I think the ultimate goal that we're really striving towards is to make sure that all calls are answered locally. Right. The system is set up at a national level where if you don't answer in a certain period of time, the call is then pushed to another community where the individual answering the phone might not know the resources as well. And so we're really trying to work towards a local answer system. And so that's the overarching goal of having, a number of NSPL centers certified and online to provide the support necessary.
Okay. Are calls answered at rapid response by volunteers, clinician, paid staff, or?
So Beacon actually employs our call takers. We do employ clinicians. We also employ paraprofessionals and peers, and a mix of those folks are answering phone calls, texts, and chats for us. Dennis, the rapid response teams have a very specific staffing model, so I'll let you talk about rapid response in particular.
Yeah, and just in terms of like the 2-person teams that come out, I didn't quite understand kind of where we were going with that one. But.
Oh yeah. No, well, I mean that's I've talked about call taker qualifications. I just thought you might want to throw in the qualifications of people who are responding in the community.
Gotcha. Yeah. So they'll, depending on kind of where we're deploying to. So if we call it safe place, so that would be like a doctor's office or hospital, school, we'll deploy with one person. And if it's a singular clinician, that will be a master's clinician. So that will be somebody who's got a lot of experience in dealing with crisis. Likely their only job is dealing with crisis. So, I think around the state, you could get somebody who is definitely going to be a master's level clinician. They might have actually been somebody, because what happened, not to go into the entire story here, Liz, but what happened was when we transferred over to mobile, a lot of the hospital-based clinicians in different regions of the state transferred from that hospital-based to mobile. And so those folks are super experienced at dealing with any kind of crisis. So a lot of those folks you'll see on the mobile side, but yeah, definitely a master's clinician. And the peer support folks, if we're doing a 2-person team to somebody's home, certified peer support specialist who has that shared experience. Both clinicians and everybody who does rapid response mobile has also been trained under this things that Beacon have rolled out. They've rolled out a really extensive training program. So they would have undergone that as well. So you're getting somebody who not only is very adept at handling a crisis, but the folks who do this work, they love it. I mean, they really live for it. They really live for coming up with different options. They're super creative in that area. So you're definitely in good hands.
Absolutely. Okay, so when the mobile team, so Dennis, I'll ask this from you, is sent to a person and they need crisis stabilization, how does that work? Do you automatically call 911 at that point?
So it all depends on how you're defining crisis stabilization, because there are some stabilizations in which the person has to kind of leave their home, right? If you look at it on a spectrum of choices from outpatient all the way to inpatient and in between, crisis stabilization can mean, that you actually stay in home, but we're going to see you the next day. We're going to check in on you. We're going to get you a therapist or a team to work with. For a more serious stabilization, we might actually get you a referral to a partial hospitalization. On the far end of a crisis stabilization, maybe it might mean that we go to the local emergency department,
Mhm.
and we look at inpatient options. I think I really love Josh's story because it highlights the fact that Josh went to the emergency department and the next day was really feeling much more safe and stronger. So that is we see that often as well on the continuum of crisis stabilization, that you might feel like in the moment, all right, well let's go to the emergency department, but you wake up the next morning and you start to feel better. So there's a lot of different options and a lot of different things to talk about when we talk about crisis stabilization. They could mean staying in home, or they could mean, going to the emergency department and taking it from there.
Okay, thank you. So what steps are being taken along the way to ensure cultural competent care at each step of the process? Eric and Jeff, do you want to take this question first?
Sure. So I know part of our training does involve some cultural competency trainings. And that includes, cultural competency is a very broad concept, right? We're talking about language, we're talking about customs and traditions and beliefs, and even, the way that someone dresses, the way that someone may feel comfortable interacting, with other people. So culture is certainly a very broad category. We've also done a lot of work directly with DHHS here in New Hampshire, the Department of Health and Human Services, and their Office of Equity, to make certain that the care that we are providing is being done so with a sensitivity to questions of culture, questions of equality, and things of that nature. So we are providing our staff with training, but honestly, cultural competency is not something you can get in 1 or 2 or even 10 trainings, right? It's an ongoing, constant learning process. And so part of our training and quality management process for our staff includes things like, were you able to serve this client effectively in this method? Were there things about the way that you interacted with this client that we might need to look at for improvement? So it is a constant quality improvement process, but we do provide our staff with training. And of course, the majority of our staff are already coming in with a lot of training and experience in this anyway, since many of them already have some level of clinical expertise and training.
Yeah, I really like how Eric kind of defined that. And It isn't something that you can go through one or two trainings. And so I know at Seacoast, for example, obviously having undergone the Beacon training, working with the state, but Seacoast spends a lot of time with our own training and our own working hard to kind of understand those issues in a profound way that goes beyond just one or two trainings. We want to live that and understand it every single day.
So what happens if you receive a call from out of state?
Well, we do our best to de-escalate, obviously.
Mhm.
We would still serve that person to the best of our ability. And, often again, we're very successful in being able to de-escalate with nothing more than that phone, text, or chat conversation. The difficulty with that then lies in if we do need to make a linkage to someone, since we are, primarily serving the New Hampshire area, we have the New Hampshire resources. We know how to link people to those services. An advantage that Beacon has is that we are part of a larger nationwide network with Anthem. And so it's possible that we may have some resources for the state for that person, but more likely than not, we're having to do a bit of, admittedly, we're doing a bit of live research, right, to try and find resources in that moment. Jeff, Jeff works more closely with call center operations. And do you have something to add in that realm?
I think you've defined it pretty clearly. I mean, we're going to do the best we can in the moment to provide support and provide coping strategies and skills, while also in real time asking about, what is the community that you might be living in? Can you tell us more about that? Can you tell us about those resources? And then we'll be researching on the side, right? We have a network of staff there present who can be researching for local resources at the same time. We also have what's called NINA as a part of our system. So on the back end, we have access to all of the local 911 call center lines. So if we were to receive a call from out of state that rose to the level of needing emergent intervention, we could pretty quickly look up the local 911 connection and link to law enforcement very, 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 very quickly.
Right. So, and there is a question about someone who is going out of state. And so your recommendation for someone who is maybe going to another state, the language may not be the same. It may not be rapid response, but they would find their local crisis support for that state maybe prior to going to out of state. Would that be the best recommendation?
I think that's a great idea, Liz. If you're planning on being somewhere and you're concerned about possibly needing services, doing some research in advance would be a good idea. I noticed there's also a question about 988 that I might be able to tie these two questions together a little bit. So there's another question that asks like what states have 988, and then of course we're talking about trying to get resources in another state. So let me explain a little bit about what 988 is. If you think back, and I have to do an analogy here. So if you think back about 50 years ago, nationwide, if you needed to call the police department or the fire department, you were generally calling a 5 to 7 digit number, right, to reach those services. Back in those days, you had to know the phone number for each of those services. And then 40 some odd years ago, depending on the area, 911 came about. And so suddenly there was the centralized way of calling one number and kind of getting routed to the service that you needed. That's the same concept as 988. There is already an existing network of suicide crisis lines. That's the National Suicide Prevention Lifeline, which is currently the 1-800-273-TALK number. And so that number exists already as a nationwide service for people who are in crisis. What will happen with 988 when it goes live in July is that instead of having to remember that full phone number, you'll be able to remember just the 3-digit number. In anticipation of the rollout of that system, there is quite a bit of funding and work going into increasing the level of local resources as part of that network. That's why this service has been enacted here in New Hampshire, because New Hampshire wanted to make sure that when this service went live in July, there were local resources to be able to provide care. So again, if you are in another state, there is a service out there. It's the National Suicide Prevention Lifeline, which you can currently reach via their 800 number. So that will be available to anyone anywhere in the country. As far as what the local resources are, that's what will vary. And that is the piece that you probably want to research before you go, if you're concerned about needing them.
Thank you. That was very clear. So I'm just going to skip down to a question for Josh. After you returned home from the emergency department, how long was it before you were connected with ongoing services and support to you?
In my case, I already had a therapist and a psychiatrist. So, I just had a psychiatrist appointment 2 days after I got home. So I didn't have to wait to be connected with anyone.
Sure, Josh, and just because you and I have chatted a little bit about this, part of your discharge plan was some increased peer support services. Can you talk a little bit more about that?
So I had a peer worker, and she became part of the rapid response team, and now I get to see her once a week, and we talk about different coping skills and talk about how I'm doing, and we just relate to each other, and it's really nice to have that peer-to-peer connection. It's really important for me in my recovery, I feel, to have that connection. And so once a week to have that is really good. And I think like that's probably the best thing that I've gotten out of having this whole crisis that I've had, was getting to talk with my peer worker.
Thank
Liz,
you,
this
Josh.
this might be a good time to talk about follow-up in general.
Sure.
You know, I think we both highlighted, you know, both the rapid response team and the access point highlighted follow-up. But this might be a good time to talk again about sort of how we connect services and how we envision the system working at large. You know, if you call the access point, and if you know, with that support during that call, you feel some sense of relief and rapid response is not necessary, there are still instances in which we would do outbound calls. We would do follow-up calls for a number of days just to check in and see how you are doing, ensure that you are still feeling some resolution or doing better as a part of the crisis episode. And then we would be asking, are you connecting with services? Are you following up with your case manager? Have you been able to schedule an appointment? In addition to those follow-up calls, there are certain circumstances in which we would also work to try and schedule you with a follow-up appointment or an urgent appointment with the rapid response team. And so Dennis, you might also be able to talk a little bit about what those appointments look like, and then any follow-up you might do as a part of rapid response interventions in the community as well.
Yeah, Jeff, you know, one of the, I think, unique things that binds the community mental health centers and the Beacon Access Point are these next day appointments. So, and Jeff and Eric have been really articulate about kind of describing this process. And so when you call into the access point, if the access point is able to resolve the crisis, Seacoast Mental Seacoast Mental Health has the following day, they have these openings. So for us, it's 12 to 3. So as an example, if you call the access point and they resolved the crisis, but you needed more follow-up visits in person, especially, the access point can tell you to come in during a certain time. At Seacoast, it's between 12 and 3 each day. And then we can kind of get the ball rolling from there with the additional assessment, maybe even set up an intake for you and whatnot. So I think that's one of the really neat features of this, is that Beacon, and it can be at 2 o'clock in the morning. If Beacon is talking to you on the phone, they can get you in to an in-person appointment the following day. Now that in-person appointment is very much an extension of what you talked about with the Beacon folks. We're going to come in and we're going to treat it like an emergency visit. Like, all right, let's talk about all the things that you spoke to Beacon about, and really it's an examination of that of the crisis. And then we sort things out from there. Well, do you come to Seacoast? Do you meet the eligibility requirements to come to Seacoast? Do you want to just come for more crisis stabilization sessions with us? Do you just want a phone call from us? So there's so many things that we can do that following day. And I think it really speaks to this partnership between Beacon and the community mental health centers that really is exciting for us.
Right. Yeah, thank you. Lots of options. Okay, there is another question in the chat. How is the labor shortage affecting the service, and how many positions are open in the state? Which we may or may not have an answer to, but at least the first part. Do you want to address that? And we can start with
Yeah, I can talk.
Dennis.
I can talk. Sorry, I can talk a little bit about that. It's a very complex question in a lot of ways, but I'll just answer it like this. Mobile Crisis is not the only new program that the community mental health centers are standing up, right? There's a lot of new ones. And so there are a lot of vacancies in community mental health right now. When last I checked, there were about 400 openings throughout the state in community mental health, and about 80% of those were clinical. Okay, obviously not all of those are Mobile Crisis, but Mobile Crisis represents an enormous program that we have attempted to staff. And I'll say that it still remains a challenge to fill those positions. Now, if you look at the manpower that the Beacon Access Point can bring to, in terms of resolving these things, you can see how valuable that is for New Hampshire, right? If incoming calls are taken care of at 75% of the time, that's great because they got a lot of virtual manpower. But yes, the shortage remains an issue throughout the state. We've been lucky in some regions to be fully staffed. If you look at the folks in Manchester, the folks at Center for Life Management, which is in the Derry, Salem area, those folks have really good staffing. But unfortunately, around the state, there are those teams that don't have the 24/7 staffing yet. And so, we're always looking for really great people who want to come on board and learn about how to help people in crisis. So if there's anybody on here now who would like to learn more about that, we certainly would love to talk to them about it. But it's an issue, and I think I've heard Jeff and Eric both say this, and I really believe this, that as much progress as we've made, and we all have to remind ourselves that it's January 1st was the jump off point for this. We're in April now. We're going to continue to grow together, our two organizations. We're going to continue to hire folks. We're going to continue to teach people how to manage crisis, and as we incorporate new staff, tell them how great it is to work with folks who are in crisis. But it will be a challenge. We're going to get there. We're still early on in the process, and to see where we're going to get to in a year or 2 years from now, I think we're in pretty good hands. We just got to grow it and build it and get there with the staffing part.
Yes, I agree.
And just to comment, so I know, I recognize, Dennis, that local resources are limited, and so that makes it difficult to hire enough folks to do the work in state. One of the advantages that Beacon has is that we are bringing in people really from around the country to be able to operate this line, because we're able to operate virtually. And so we don't necessarily just have to look in New Hampshire for people to answer the phone. So we've been able to actually have quite a bit of success in staffing. We have identified that we need to add some more staff, just given what was admittedly an unexpectedly high volume of calls, and we're doing that. But we've been able to do that pretty easily. So at least as far as the call center, staffing has not been a major concern. And understandably, it has been for the services around the state.
Thank you. So Josh, I'm going to jump to another question for you. Curious about your experiences around the difference of going to the ER after your crisis or for your crisis and the mobile response versus going directly. What made this response better for you?
So when I've gone to the ER before, when it did not involve the mobile crisis team, sometimes the ER waiting time seemed longer. I also had to wait for blood work. I had to say my story to the nurse, the doctor, and then wait for an evaluator to come in, say my story to them, wait for them to look for a bed if they were going to send me inpatient, and like do all of that stuff. And with the rapid response team, I only had to tell my story once or twice, and I didn't have to do any of the blood work or any of the medical waiting stuff. And I also had a peer worker came with the evaluator, which was really nice.
Okay, thank you. What have been the biggest challenges with this new system?
I'll start. I think one of the challenges with any new system is that you don't always know what you don't know. And so I think as well as we planned, and as great as everything was on paper, the reality sometimes doesn't match what your plan predicts. So there have been some very kind of rapid last minute adjustments in the way that we do things. It has required us to really be in very close, constant communication, not only with DHHS, but also with the CMHCs. But I think we've done actually a really good job at that. I'll just, and not to sound overly positive about it, but honestly, I don't think that there has been a major issue with the service since we began. I think that the issues that we've had have all been relatively, minor or moderate, and we've been able to work through them pretty well together by having that open communication. Dennis, you may have a different perspective as a CMHC rep.
Yeah, I mean, I think we all anticipated there'd be some challenges out of the gate. But I'll tell you, having been in multiple meetings with Jeff and Eric, I've even seen Jeff in person. The Beacon folks worked exceptionally hard at refining the process, and I think we've been great partners in that way. Both entities working extremely hard to fix any of the glitches and stuff like that. So I think what we have in common is that passion. We all love the work. We love helping people get beyond their crisis, and that passion, you see that. I mean, I see that passion every single day, not only in my staff, but just when we're in meetings with Beacon, we're trying to resolve some of the challenges, and there's just a tremendous hard work on both sides going on. But I think one of the other challenges has been, and this happens all behind the scenes, really, is one of the challenges is trying to get the best team to you. And this is kind of, folks who are getting the services would never know this because they just know that they're calling and the team's coming out. But there's some behind the scenes work that sometimes goes on where we look at if somebody's calling from a particular area, we try to always match up the team from that area. It's not possible all the time. But if somebody was calling from the Seacoast, I know we try to work hard on getting a Seacoast team out there because we likely will know the situation. And if you know the situation in advance, that's a good thing because you just have so many more options. If by some chance the police were on scene, you can just talk through the situation a lot better because you know the case. So sometimes behind the scenes, we're trying to find the team that knows you the best. I mean, somebody might be available and they might be an hour away, but another team might be just shortly after that, and they might know the situation a lot better. So there's just some behind the scenes things that I think we try to get right and work on. But the level of hard work that's going on between the community mental health centers and Beacon, it's just, I mean, it's tremendous.
Thank you for bringing that up, Dennis. I appreciate it. And I'll just continue with this question because I think it's really about mobile crisis response teams. How do you pay mobile crisis response teams? Are they paid regardless of their response hourly? Are they per diem? Are they salaried? Is it on-call pay? That sort of thing.
Kind of like the fire department. So basically, there are some days where there's nothing going on, and you, as a clinician, as a peer support person, you would still get paid. So you don't get paid by the number of crisis that you intervene on. You get paid by when you're on and when you're available to work. So yeah, it's definitely not a situation where you'd only get paid when there's a crisis, right? And same for like a per diem person. If you, for example, could only work a Monday overnight, you would be on for Monday overnight. And if you didn't get any calls or any deployments or anything like that, you'd still get paid. Hopefully that answers the question.
Yes, I think it does. So can we talk a little bit about the connection with law enforcement, and if there's a connection and what that looks like?
Yes, we've done a lot of work on that. In fact, one of the state committees that I chair is the law enforcement mobile subcommittee, and it's a topic that I really love to talk about. And what's so exciting about it is the law enforcement folks in that community, they love mobile crisis. They love mobile crisis because, let's face it, and they'll be the first to tell you this, law enforcement, they're not social workers, they're not clinicians, they don't understand a lot of these situations. Even with the incredible training now that they undergo, the CIT training and things like that, law enforcement have been focusing more on mental health now than they ever have, and I give them a tremendous amount of credit. But yeah, they'll be the first to tell you that they don't, they're not clinicians. And so they have been put in situations over the years where, not knowing what to do, they'll just bring somebody directly to the emergency department. Of course, we know that there's a lot more options than that, but the police are excited about it. We always talk now in this subcommittee that I run that we're all in the same circle. So the clinicians are learning about how the police do their stuff. They're learning about how we do it, but there's an incredible amount of collaboration now that's happening between the community mental health centers and the mobile teams and law enforcement. And I think just each day and each month that we're intervening together, we're getting to know each other's first names and getting to understand each other's process. And we had a situation in Portsmouth recently. We were all out there together, and you could just see how people were becoming more comfortable being in with the law enforcement, being in with the social workers and the team. And those folks, the law enforcement community, they really care about resolving the crisis as well. So we're all coming in and working together now, but it's going to be really neat moving forward to see how that collaboration evolves. But it's going to be a really great thing. I know the law enforcement leadership around the state is super excited about having some in-person consultation and mental health clinicians that they can help resolve these situations. So I'm really thrilled about that collaboration and where it's going to be as we move forward.
I think maybe one thing to add to that is just really how that helps improve the intervention, right? So when an individual is in crisis in community, it can be hard if law enforcement shows up and doesn't know the resources, and they react by wanting to take someone to the emergency room. I think all of this collaboration that we're talking about really helps improve the crisis intervention, right? So when suddenly you have law enforcement when necessary, and you have a trained clinician, and you have a peer support specialist, you can provide a much better service in the community, so the person is more comfortable managing that crisis. And so I think the end goal is to provide a better intervention in the most efficient and effective way possible. And I think all of this collaboration and coordination is really helping improve that measure of service.
Yeah,
Yeah,
that's
and
really well said.
I'll jump in and add as well. I mean, collaboration has to happen in the moment, right, on the local level, but collaboration has to happen as a system as well, right? And it is happening as a system. And that's really, I think, one of the major key components of a successful crisis system. A crisis system, no person in the crisis system operates in a vacuum. They have to know their resources. They have to have those relationships. They have to already have, understanding of how these things are going to work. And so I do want to address, Michelle brought up a question in the Q&A about the work groups. So we are hosting a series of crisis collaboratives in each community. I'm partnering with each of the CMHCs to get those going. I'm also in the process of hiring a couple of staff members on my team specifically to head that initiative up. Those are going to be opportunities for Beacon to sit down with the CMHC and also people from the community. So of course we're going to have law enforcement, school personnel, hospital personnel, social services personnel, but they will also be open to the public for people to come and learn about the system, provide some real-time feedback about the system, and help shape the system, right? We've said a few times in this presentation that we want to serve the population. And the reality is that, we need to know if what we're doing is serving the need here. And if it's not, how do we adjust so that we are serving the need here? That public feedback is really critical and crucial. So I'm putting a plug in, so to speak, for the fact that we are going to start having those meetings, and we will work with each of the local CMHCs to get those advertised and mounted.
And absolutely, Eric, you and I have talked about how NAMI New Hampshire can share that message with our community too, our network of support groups and education programs. We're happy to get that word out.
Thanks, Lynn.
And I know the other question you wanted to address, Eric, was can someone else call for the person needing help, or does the person need to call for themselves?
Yeah, I wanted to be sure to answer this question because I think it's important. It's not necessary for the person themselves to be the one that calls or reaches out. We do have the ability at times to help if a third party has reached out. Now, of course, it does present some specific challenges when you've got someone calling on behalf of another person. There's a lot more coordination. There may be some additional questions that we have to ask to figure out. One of the primary things that we think about when we're looking at care, and Josh has been so great to point this out, is we really do want the person to have the ability to give feedback and be involved in their own decision making. So if we do get an inquiry from a third party, we're going to ask if it's possible to engage the individual. We do understand that there are times when that individual may not be in a place to engage with us, but there are still legitimate concerns about that person's safety or well-being. And so we are able to explore options. We might be able to dispatch mobile crisis depending on the situation. We might have to dispatch out some sort of emergency service, or we might be able to help the caller discover a local resource that they could perhaps engage with for that person. So short answer is yes, anyone can call for any person. The more complicated answer is if it is not the person calling for themselves, it just does create a bit more work to make sure that we're providing the appropriate linkage.
Absolutely. So I am just going, okay, here we go. Will the 988 call from headrest have to be transferred to Beacon if there is a need for mobile response? How would that work?
We're working really closely with headrest as we approach 988. Beacon is currently the dispatch point for the mobile crisis teams. Headrest does have to currently connect with us to make that dispatch happen. But we are working on ways. I talked about kind of this back room or backdoor processes that we're putting in place. And that's one of those processes that we're developing with Headrest so that we can do that relatively invisibly to the public, right? So that Headrest can reach out to us and alert us of the need to dispatch mobile crisis without the caller having to necessarily go through additional steps to make that happen. So we're working on that process. Right now, it does involve a transfer from Headrest to Beacon as we figure out the best way to make that happen more seamlessly.
Okay, final question. What are you learning? What are you learning is important in your data collection? Any surprises that have now added tracking mechanisms for you that you didn't initially?
Well, I mentioned in passing earlier that the call volume has been more significant than we anticipated, right? So tracking that information is helpful to us because it's now driving decisions around staffing. So that's an example of how good data tracking can really inform your operation of the service. I would say that for the access point, that is the call takers, understanding our call volume is probably one of the most critical things. However, there are a number of data points that we are tracking and trending related to our performance, related to the communication that we're having with the CMHCs, and some general high-level understanding of the population that we're serving. So, Jeff, I don't know if you have things to add on data collection for us, and I'm sure, Dennis, you have comments for the CMHCs.
Yeah, I think just quickly, we're constantly analyzing the data to help refine staffing. When do we need staff on to answer call volume? How do we most effectively do that? And we have a number of systems in place. We get daily reports on the number of calls that are coming in, how long it takes to answer those calls. So we're able to see that data on a regular basis and adjust staffing to make sure that we're responding effectively. And then more data analysis will be happening on exactly who is calling in and how did we handle each call and what can we do better.
I think real quick from a data perspective, one of the things that was kind of surprising to me, again, kind of coming from that hospital-centric emergency services, but when you're out in the community, you realize that the highest percentage of people do not need to go to the emergency department. And so then now it's really surprising because when you're working in the emergency department, you think, well, everybody should come there, but you realize pretty quickly that there's so many options to folks just staying, in their home and starting services and following up with them. And I think the highest majority of folks will get to do that.
Great, thank you. Thank you to our panelists for joining us today. And thank you so much, Josh, for joining us and sharing your personal story about the service. We really appreciate that. And thank you for all the questions. That was a really pretty robust question and answer session. I really appreciate everyone taking the time to ask more questions about this new resource for folks. So just as a reminder, an evaluation will be emailed to you. We really appreciate you taking the time to give us some feedback on this session, but also on the conference itself and other sessions for today. This session was recorded and it will be available on the YouTube channel and the Whova platform for the next 30 days. Head on over to the community boards on Whova so that you can chat and talk about anything after the session. And up next at 12:15 is the NAMI Walks New Hampshire rally. So we look forward to seeing you then. Thank you, everyone. Take care.